thyroid disease. Know the facts. Coming up next on Call the Doctor. Vital information you need. You are not alone.
Call the doctor.
Call the doctor.
Call the doctor.
The thyroid, it's a butterfly-shaped gland located in the neck just above the collarbone. As one of the endocrine glands, the thyroid creates hormones that influence the metabolism, growth, and development of our bodies. It regulates how fast we burn calories and can influence our energy levels. There are a number of disorders that can affect your thyroid, from goiters to hyper and hypothyroidism to nodules or even life-threatening cancer. Unfortunately, thyroid cancer is on the rise throughout America, with Pennsylvania leading the nation in the disease. In fact, many of our local counties have the highest rates of thyroid cancer in the state. To diagnose thyroid disease, doctors can use medical histories, physical exams, and thyroid tests, including biopsies. Treatment depends on the particular problem, but may include medicines, radioiodine therapy, or thyroid surgery. While it's important to recognize the symptoms of thyroid disease and schedule regular medical checkups, the good news is that there are successful treatments available. Even thyroid cancer, when treated correctly, has a high cure rate. Welcome to Call the Doctor here on WVIA TV. I'm Paula Giacomo. Tonight, our topic is thyroid disease. Joining us on the panel are Dr. Gregory Borowski, specializing in endocrinology, diabetes and metabolism, and internal medicine. He's from Horizon Medical Corporation in Scranton. Dr. Jacqueline Oxenberg, Associate Surgical Oncology from Geisinger, Wyoming Valley Medical Center. And Dr. Madhava Baikati, Radiation Oncologist from Northeast Radiation Oncology Center in Dunmore. I'd like to thank our panel for joining us tonight. And I'd like to remind you, the audience, that viewers can participate by commenting along with the conversation at wvia.org/CTD. Now we can begin the discussion. Doctors, at least 30 million Americans have thyroid disorder. Half of those don't even know they have it. They're suffering in silence. What are some of the symptoms, and how can people get tested to find out if they have a thyroid disorder? Dr. Borowski?
Well, thyroid disease is very common, and the symptoms, fortunately or unfortunately, are very non-specific. You know, if you walked in here and said, I've got chest pain, well, a few good tests and a few questions, I could figure out the 8 or 10 causes of chest pain. Unfortunately, with thyroid disease, especially hypothyroidism where it's underactive, the symptoms are very non-specific. They can be things like fatigue or dry skin or a little bit of constipation, etc. Unfortunately, a lot of those symptoms now open up the textbook of medicine, maybe 200 or 300 different diseases that can present the same way.
That sounds like everyday symptoms for some people.
Exactly. So we get so many people come in and they come in with their laundry list of symptoms and saying, I got thyroid disease, look at all this. And say, yeah, but you could have all these other diseases as well. So the biggest thing is trying to sort out what kind of symptoms are attributed to thyroid disease, and perhaps maybe what you may not have thyroid disease, but maybe some other disease. Fortunately, very easy blood tests can usually determine very accurately whether or not you have different types of thyroid functional disease, at least. Mm-hmm. People can also present with, as mentioned in the introduction, with some type of anatomical or physical problem, such as a goiter, which is usually a diffuse thyroid enlargement, or nodules, etc.
Or if you have trouble swallowing, or...
That might be attributed to something like that, yeah.
So then, is there a medication to treat this disorder if you have hypothyroidism or hyperthyroidism?
Yeah, usually thyroid disease can be kind of sort of divided into very quickly into sort of 5 different types. You can have a functional problem where it's overactive or underactive, as you mentioned, hypo or hyperthyroidism. You can have an anatomical or physical problem such as a goiter, or diffuse enlargement, or lumps or bumps. You can have just positive blood work for what we call antibodies, which just means you may be predisposed to thyroid disease in the future. Or you could have tenderness in the thyroid gland, where there's like a thyroiditis or an inflammation in the gland itself, or there can be involvement of some parathyroid structures as well. If you have an underactive thyroid gland, there's medication available for that. Usually it's something called levothyroxine is the generic name. Very stable compound, very easy to take. and from one batch to another. If you're overactive, then there's various treatments. You could take medication, you could undergo radioactive iodine therapy, or potentially surgical intervention is also an available option for that type of therapy.
So, Dr. Oxenberg, you're a surgeon. If someone has a lump or a goiter, that's where you would come in. Is the treatment to operate and remove that lump?
It depends on the cause of the lump. If we ultrasound everybody, about half of patients would actually have nodules. Most nodules are not problematic. The thing that we have to sort out is, are they going to become a problem? Are they causing the symptoms? Or is there a potential that they are cancer? Mm-hmm. Where I step in is the potential that they're causing problems. When they get to a certain size, sometimes they do cause problems. They do cause problems swallowing. They can cause compression on the nerve that controls the voice. And sometimes there's a sampling error too. So for large nodules, even though they may be benign, sometimes we do remove them.
So if you do remove it, how serious of a surgery is that, and how quickly can someone recover?
So the recovery is usually pretty good. The pain is more of a sore throat, because the thyroid, as we saw in the introduction, actually wraps around the airway, and behind that's actually the esophagus. So the manipulation of that, the most common complaint is actually maybe a sore throat. The most dreaded risks, but very uncommon, is the risk to the nerve, to the voice box. Mm-hmm. A little bit more common has to do with the risk to the glands that control our calcium. Mm-hmm. And a little bit of a risk is the nerve that controls the pitch of the voice. So those are all things prior to surgery. We do assess patients' symptoms to determine, what the best course of action is.
And another form of treatment, Dr. Baikarti, is radiation, iodine radiation. When would that come into play?
There are two different diseases. One is benign problems with the thyroid. When the gland is hyperactive, we give small doses of radioactive iodine and to suppress the gland. If for cancer of the thyroid, the most common ones, papillary carcinomas of the thyroid or follicular carcinomas of the thyroid, they are commonly treated with iodine. And iodine, the thyroid gland uses iodine to make a thyroxine, which is the hormone that is secreted by the thyroid. So radioactive iodine is like a lock and a key mechanism, because that's the only gland that uses iodine, and the radioactive iodine is incorporated into the cell within the thyroid gland and destroys that particular thyroid tissue. So the mechanism of action is very simple, and it spares unnecessary radiation to the neighboring structures, the parathyroid glands, and those are critical, and spare some of the nerves and the esophagus from the high doses of radiation.
And I leave thyroid, if the thyroid does get stuck to the area of the trachea where the nerve does go into the airway. So when Dr. Baikarti does treatments such as radioactive iodine, it actually ablates whatever remnant thyroid tissue may be left. So if we're treating benign diseases such as hyperthyroid tissue, it actually will, it can ablate if there's continued remnant thyroid. That helps that treatment. If there's a possibility of cancer left behind at these areas, we have the capability of sparing the nerve to preserve a patient's voice, and then treating them effectively with radioactive iodine as well.
Okay. Now, 1 in 20 have hypothyroidism and hyperthyroidism, so it's pretty common. Are there any ways to prevent it, or is it something that's genetic, or it just develops as you age?
Most thyroid disease, at least the functional part of it, is mostly autoimmune in nature. It means you've inherited certain genes from your parents that are responsible for either making antibodies that stimulate the thyroid gland in the case of, say, for instance, Graves' disease, or destroy the thyroid gland in the case of what we call Hashimoto's thyroiditis or thyropivic hypothyroidism. And so most of that is very strongly autoimmune. Now, in very mild cases where your TSH, which is a very, very sensitive assay, and pretty much if that's normal, your thyroid function is probably going to be normal with rare exception. In those situations, unless your TSH is markedly off, markedly elevated, like a normal level might be, say 0.5 to 5.0. If you're between 5 and 8, most likely you may or may not have some very, very subtle symptoms, as some of I mentioned before. And if you're beyond 8, then you start getting a little bit more symptomatic. And If your levels get up to 30 or 40, then you might have more dramatic symptoms. You might be a little sluggish. You might have perhaps maybe a couple pounds of weight gain, etc. And then that's where treatment comes more important into play. When you get into the 8 or below range, supplemental thyroxine may or may not help some subtle symptoms, but it's not going to make a lot of difference. I get a lot of people come in the office with normal TSHs and they have all these symptoms, and obviously it's, as we've started the whole conversation, is probably it's not your thyroid that's causing that. There may be a lot of other reasons of doing that.
But is it still a good idea to get it checked, just to rule it out?
Yes, it's a very simple panel. You kind of attach that along with your CBC and chemistry now. You know, years ago we never used to do screening panels. Now everybody gets a screening panel.
Are mild and moderate forms of hypothyroidism more difficult to detect? Is that because of what you were just saying?
Well,
the symptoms could be...
Yeah, probably the most one that's a little bit more difficult is when your TSH is between, say, 5 and 8, because there you can have a few subtle symptoms, like maybe just a little bit of fatigue, maybe some dry skin, coarse hair. Once you get, if it's in a normal range, you probably aren't going to have many symptoms that are going to be attributed to that. And if you're beyond 8 or 10, then probably you're going to have some symptomatic symptoms. So those are a little bit easier to sort of deal with. It's the one that's in between that's a little bit more difficult.
Now, if you have a goiter, is it only when a symptom like that shows up that you have to worry about cancer, or can you get thyroid cancer from other symptoms, like not having a lump?
So cancer is slightly more common in autoimmune disorders of the thyroid. The problem with goiters is that they can compress the structures around them, including the airway. So as a surgeon, I do offer surgery when it does become a sizable thyroid because of the extension.
So what I'm asking is, if you have a thyroid disorder, can that lead to cancer?
Well, most often if you have small nodules in there, in your thyroid gland, and a lot of people do screening ultrasounds now, and that's where they're picked up. A lot of times if you were doing an ultrasound, for instance, on you for carotid arteries to check your carotid artery flow, you'll pick up the thyroid in it and nodules will be picked up. And the problem is it's very sensitive, because if I did an ultrasound and say 10 women that walked through the door, probably 7 of them would have some type of nodules in a gland. And trying to sort that out is sometimes a little bit more problematic. However, the American Thyroid Association just revamped their criteria, because actually we were probably doing too many biopsies on these people, because we're doing really tiny nodules, and then even if we developed maybe a small suspicious cancer and a very tiny nodule, the bottom line is, in general, papillary and follicular cancer have a good prognosis, so that very few people die of actual thyroid cancer. Although again, if it's cancer and it gets big enough, you certainly want to take it out and treat it. But the problem is that if you biopsy somebody and it's a very small nodule, that may not grow or metastasize for years and years and years. So now there's some people that are even on the fringe of saying, well, even if we diagnose a small cancer, do you necessarily want to have that taken out, or just watch it and see if it grows? So that's something that's up in the air now. But nodules usually have to be somewhere, I'm just going to throw out a number, probably somewhere about 1.5 to 2 centimeters before you start getting a little bit more suspicious about doing firm biopsies. And then if you look at them, if they have certain types of calcifications and things, might be something else might throw it in one direction versus another.
Okay, so it all depends on the nodules and the size of the nodules.
Correct.
And
right.
whether or not you could even biopsy those nodules.
Depends on the ultrasound criteria. The surgical criteria is about 1 centimeter with suspicious features, and 1.5 without, and that's solid forms. Now there's nodules that can be solid and cystic as well, so it's the solid component that's important.
And there are different types of thyroid cancer. Some are more treatable and others are rare and harder to cure. Is that correct?
That is correct. There is papillary and the follicular forms of thyroid cancer that are easily treatable and mostly curable. Then there are the ones that we rare, but anaplastic carcinomas of the thyroid are universally fatal. There is no good treatment for this as of yet. So that is a bad cancer to get. Fortunately, that is very rare. Then there is the medullary carcinomas of the thyroid, and that occurs in the group of other endocrine abnormalities, either from the parathyroid or from pancreas or pituitaries and so on and so forth. So they have with that particular syndrome classification.
Are there any advances in treating thyroid cancer that we could highlight that could give people hope?
So I think the advances not necessarily are treating cancer, but the problem we have with one of the types of thyroid cancer, specifically the follicular cancers, is we cannot diagnose follicular cancer until actually doing surgery. It is the invasion outside of the nodule into the surrounding tissue or blood vessels around it that we can actually call it follicular cancer. So we now offer an RNA analysis to help guide what type of treatment I may be able to offer.
Okay. And is there any way to prevent thyroid disorder or thyroid cancer?
So the number one risk is still radiation. Preventing exposure to radiation, in certain workplaces is very important.
Okay. Why are women 10 times more likely than men to develop a thyroid disorder?
That's a good question.
There is no good answer.
Because they're female?
Yeah. Well, again, a lot of it is genetic as well. So, but why women have it more commonly than men is still not a real good answer to that.
Okay. And what about clinical trials? Are there any clinical trials that can help people?
The clinical trials, because our treatments are so effective, the clinical trials are pretty limited.
Okay.
In general, clinical trials help test types of treatments, and it's when other treatments usually fail is when we look for other types of effective treatments. And at this point, most cancers are very treatable with actually surgery in addition to radioactive iodine alone, with actually almost a 5-year survival with the most common types of cancers of about 90 to 95%.
Oh, that's great. So it's not necessarily a death sentence.
Right. So, and even the patients, especially if they're younger patients, still do very well. So clinical trials are pretty limited and would be for more advanced disease. In terms of surgery, I'm not aware of any.
Okay.
I don't know if you know of any.
I think it's been one of the good problems about this disease is that over the years, because thyroid disease in general, especially papillary and follicular, they just grow so slowly that because some people can harbor a nodule in their thyroid for 8 or 10 years, and then finally somebody says, hey, let's biopsy that thing, and then you biopsy it, turns out to be a cancer, and then you go and remove it, and it's completely excised. But even people who have even a few lymph nodes in their neck after you do the dissection, which obviously means you've had some local metastatic disease, even in that therapy, if you go in and take the lymph node, most of your lymph nodes out within that surgical field, and then give them radioactive iodine, most of those people live a long time. And so the survival rates, even at, we don't even talk too much about 2 and 5 year survival rates. We talk more in terms of 10 and 25 year survival rates.
That's great.
And that goes back years and years and years to some of the early investigators like Ernie Mazzaferri and so on, who followed papillary and follicular cancer for years. And that's been one of the problems with trying to figure out, is there any really more effective way to treat metastatic disease, only because it doesn't kill people very often, which is a good thing. And maybe it's because we have been doing it right for all these years. We've diagnosed cancer, we do surgical intervention, and we do radioactive iodine therapy, and that's been the mainstay of treatment. And I think that's probably one of the reasons, in addition to its slow growth, that why people live so long with the disease.
Now, if you have thyroid cancer and you have your thyroid gland removed, does that person then have to be on hormone replacement therapy because your thyroid regulates your hormones, correct?
So if I remove half of the gland, and not every single patient needs their entire thyroid removed.
Okay.
If I remove about half of the gland, correct me if I'm wrong, but less than half of patients may actually need thyroid replacement. So it's not necessarily true. Obviously, if I remove the entire gland, they will need thyroid replacement.
Because your thyroid regulates your hormones, metabolism, calcium, everything. It's a pretty important gland.
It's important.
Well, then what are the side effects then if you do have to take hormone replacement therapy? I haven't heard good things about that.
No, it's usually not a major problem. The biggest thing is finding out what the dose is for you, and that's very variable. A little bit of a guide is it's kind of weight regulated. However, that's only one guideline, and some people need a very small amount, sometimes 25 or 50 micrograms. Some people need a large amount, sometimes 300 micrograms, and there's a whole bunch of in between. But if you take it every day, roughly about anywhere from, say, 30 to 60 minutes before your breakfast in the morning, usually you get good results. The nice thing about it, it has a very long half-life. Like the half-life of thyroxine is probably 7 to 10 days, so that if you miss a dose now and then, you're probably not even going to feel it. Now, if you miss it consistently, you will eventually feel it. But that is pretty much a situation where you can take it on a regular basis, and it's relatively inexpensive. Levothyroxine is probably $10 for a month's supply, or even less than that.
And would you have to be on that medication for the rest of your life?
Correct.
Okay.
The one good thing about sometimes when we do a surgical intervention, if we just have a nodule in one side, usually the procedure of choice is to go in and take out the lobe. And if it's small enough, usually a centimeter, and now you're getting a little bit liberal in terms of a little bit more than that. If it looks well differentiated, it looks like it's encapsulated within one thyroid gland, sometimes we only just leave we just take out the one lobe and leave the other lobe in place. That's sometimes a common operation, in which case then you might not need thyroid replacement, because your thyroid the other part of the thyroid will pick up it's what it needs.
What about follow-up care? I mean, what's necessary following the surgery?
So immediately following the surgery is managing symptoms if they're having calcium issues or any problems with their voice. Again, that's rare, but important. If they have cancer, then it depends on the type of cancer. The most common types of cancer are typically followed with a set of lab work to start with. And if that's abnormal, then that's when we determine if the patient needs additional treatments. It depends on the pathology. If there was a cancer found, and how big it was, the risk factors for it spreading to other areas, and that's when we determine what other treatments they need. So that is the aftercare.
Okay. What is the rate of reoccurrence for thyroid cancer?
So it depends on what it is. The recurrence for papillary cancer
Which is the most common.
Which is the most common. Is actually pretty rare. It can spread to the lymph nodes, but we actually pretty effectively treat it. That is the most common place for it to occur. I don't know the exact rate though.
I mean, is it common?
Because it's pretty.
And that's a good thing, because it's exactly right. I've been in practice 33 years now, and really I've only had maybe 1 or 2 patients that have died of metastatic papillary cancer, and that's because even if you have some positive lymph nodes, when you treat it effectively with surgical removal of the lymph nodes plus radioactive iodine therapy, and then if you even have a recurrence, then radioactive iodine therapy can be used again to further reduce the volume, because it travels so slowly and metastasizes so slowly. It's not the same. It doesn't give you the same connotation as, say, other types of cancers like breast cancer, colon cancer, lung cancer, and so on, which can be much more aggressive cancers. So that's kind of been the good thing. It's been sometimes hard to determine incidence rates because very few people die of thyroid cancer.
So if you're feeling symptoms, whether it's fatigue, nervousness, weight gain, weight loss, should you go to your primary care physician? Will they administer a blood test, or will they send you to an endocrinologist, someone like you, who will then
No, I think probably everything starts with primary care. I think that's probably the wisest thing to do. If you have symptoms, that's where you really should start all the time, because it may not even be thyroid disease. Could it be anxiety? Could it be depression? Could it be something else that's bothering you? Maybe a heart arrhythmia or something. So you need to start there and get the blood test done. And like I said before, usually if the blood tests are pretty normal, that kind of sort of rules out a functional problem of thyroid disease. And that takes away a lot of the systemic symptoms that you might have, and then it probably might be something else. So I think that's probably the best place to start.
Okay. So the key is, if you're feeling any symptoms that are, out of whack for you, contact your physician.
Correct.
Okay, thank you. Well, once again, I'd like to thank our panelists for participating in our discussion on thyroid disease. For more information and to continue the conversation, be sure to visit wvia.org/CTD. I'm Paula Giangiacomo for Call the Doctor. Thank you for watching.